Ladies and gentlemen, it's a privilege and a pleasure to be here and give a presentation, being invited by the organizers. And let me bring you the best wishes and congratulations from the European Psychiatric Association to all of you for obviously doing a wonderful job with this great Congress here. So the topic I have chosen is the future of psychiatry. Psychiatry, of course, we are not alone in the world, but let me focus on this discipline and let me focus on a European perspective of it. This is what I'm going to talk about briefly: the identity of psychiatry in Europe, challenges and future developments of European psychiatry. And let me just take out 3 focal points, and that's community mental health care, education, and the image of psychiatry. And then let me conclude. So when we look a little bit into the past, and of course these are only few people whom I could mention here, the development over the last 200 to 300 years, if you want, starts between the poles of neurobiology, we would say today, and the psychosocial perspective on mental health and mental illness. And you see there were gentlemen who were so-called psychicists, or they were, I can't show it, somaticists, or they were psychoanalysts, psychopharmacologists, and so on and so forth. And you see the first 2 gentlemen, and this one which is shown there is Heinroth. Ryle, even before him, was the first to coin the term psychiatry. And from then on, a systematic development on psychiatry took place. Here on the left side you have Griesinger, then you have Freud, whom you know very well, Jean Delay in the field of psychopharmacology, the first person, then a social psychiatrist from Germany, and as you see at the bottom, Arvid Carlsson, who got the Nobel Prize for his work on the dopaminergic system. And finally, where we are now is that mind and brain are reunited. No more 2 poles. We are talking about mind and brain, and also about the environment, not the least since the spectacular findings of epigenetics. We know that, of course, the environment has a bearing on mental health and mental disorder. So what then is, so it doesn't move, no. What is psychiatry? How can we operationalize it? How can we define it? And here just 3 perspectives are meant. Psychiatry is a medical discipline, it is a medical specialty at the same time, and it is a medical profession. And all of this covers a lot of activities, just to mention diagnosis, treatment and service, prevention and rehabilitation. So what then is the psychiatrist? Just let me give you this quotation from Glenn Gabbard, a psychotherapist from the States. And he says, psychiatrists occupy a unique niche among the medical specialties in that they are the integrators par excellence of the biological and psychosocial in both diagnosis and treatment. So we shouldn't talk about a brainless mind or a mindless brain. It's both which we have to focus on, and I think this is mainly the task of psychiatry and the psychiatrist. From psychiatry in Europe to European psychiatry, what makes the difference here? We would say the unifying feature on the level of the medical specialty and the clinical and basic sciences makes the identity of psychiatry in each of the countries. When it comes to European psychiatry, we may also take into account the common roots, which I just briefly mentioned, the common values, the joint action of European psychiatrists in different fields, not forgetting about the national diversity and variation. And there is an aim to achieve common standards and goals of quality of mental health care. So we could say the unifying features are shared European history, ethical values, and scientific standards. What are common values? Just to mention a few, and you may think about more. putting patient interests first, respecting patients' rights, respecting diversity at the same time. The scientific foundation of our discipline and the field of mental health and mental health care, the evidence base, the informed consent, the shared decision-making, as much as possible free from coercion, non-stigmatizing, the accessibility of our institutions, and finally, parity and inclusion as the most highest goals. So the EPA, the European Psychiatric Association, has meanwhile 40 national psychiatric associations as members from different countries in Europe, not only from the EU. We have 24 out of the 28, or now maybe 27 countries after the Brexit, of EU national associations, but there are also 13 more coming from the rest of Europe. And as you know, Europe, depending on the definition, has about 50 member states, and this is much more, that's double what the EU represents from Europe. So the statutory aims and the objectives of the European Psychiatric Association is very much in accordance what we are talking today and tomorrow on this Congress. The EPA is to improve the quality of mental health and mental health care throughout Europe by a number of means. For instance, education and training, research and clinical practice, public health policies relevant to mental health, ethical standards, and many more. Psychiatry in Europe nowadays is facing a multitude of challenges. Again, to name only some examples, we are dealing, as we have seen several times this morning, with the high prevalence of mental disorders. The harmonizing of mental health care standards is a common goal, I would say. The movement from institutionalized to community-based mental health care is a goal for all of us. Recruiting young psychiatrists in our field is very important because they are the future of our discipline. So we need to harmonize training curricula across Europe. We need to improve the image of psychiatry and the psychiatrist, and I will come back to this a little bit later. And we have to commonly fight stigmatization of the mentally ill and their families. So altogether, a move towards a European psychiatry with common standards and goals is desirable, it is needed, but the achievement, however, is an ambitious goal. So let me focus on these challenges and future developments of European psychiatry, starting a little bit with community mental health care. I think everybody knows what is meant here. We can inspect some of the dictionaries or other documents. I think the importance is that we should have a comprehensive range of mental health services available and accessible to all members of the community. Community mental health and health care is a decentralized pattern of service. It should supplement and decrease the more costly inpatient mental health care delivered in hospitals, and it is based on a variety of different community settings which are cooperating and collaborating with each other. There are European core values and visions for mental health, and we have heard from Dr. Saxena already on the basics of the WHO European Mental Health Action Plan. These core values are also inspiring or have inspired the Mental Health Action Plan, and these are fairness, empowerment, safety, and effectiveness. We are all, I think, together on this page when it comes to the question whether these values are very important. So when talking about community mental health, we would expect that the number of beds in many countries, and these are just the EU countries, should be much lower than it is. And you see a wide range over the different countries still, and even somewhere there is an increase in beds and not a decrease, and there are some countries who are very low and some which are very high. Belgium, for instance, is very high. Italy is very low, as everybody knows, and you see on average, this is the EU 28, the left side column. This is the average across all countries in the EU. So community mental health care in Europe is on its way. There is an ongoing shift from institution-based or long-stay mental health care to community-based services. Some countries provide still long-stay hospital care. Others are in transition. I think your country is in transition in that direction. Our country in Germany is in transition on the way to community-based mental health care. But still, there are lots of variations and gaps which have to be closed over the next time. This is an example from my own region in Düsseldorf, where we are, during the next 5 to 10 years, are planning to bring together all the services which are available, centralized in the sense that we will have a community mental health center which is coordinating the treatment and care across this region of about 600,000 to 1 million people. This is not much, but it is an example, it is an experiment, and we are looking forward to do so. Education. I'm talking about postgraduate education here, and just to make clear that there is a big diversity of psychiatric training curricula across Europe. The only requirement is currently to move from one country to another as a psychiatrist to show a minimum postgraduate training of 4 years. But the range is from 1 year in some countries to 6 years in few countries. And the question is, where is the right average? Where should we move? We just heard from Professor Kekilice about the situation in Russia. So this is interesting to see. In my own country, in Germany, we have 5 years, out of which 1 year is mandatory to go to neurology. So a lot is to be done here to harmonize this a little bit more. And you may know the Union of Medical Specialists in Europe, which is working on this in particular. They have brought forward the profile of a psychiatrist, which refers to the CanMed model in this field. And you see, a psychiatrist should be an expert and a clinical decision maker, a communicator, a collaborator, a manager, a health advocate, a scholar, and a professional. So how could we put all of this into a curriculum, and how long should it be? These are questions which we have to answer. So the key questions are, which key contents do we need to be covered? Which key competencies and skills need to be taught? Which teaching and examination techniques are most suitable? And finally, how long should a curriculum be? Working towards this goal is vital for the future development of the profession and beyond. So a final point, which I think may never miss in a conference like this one, is the image of psychiatry. What about the image of psychiatry? Not of the psychiatric patients, but of psychiatry itself. What do we know about it? A few years ago, together with Professor Sartorius, we, on behalf of the WPA, we organized a study across several regions of the world, asking psychiatrists and general practitioners whether they felt stigmatized in some sense in their discipline and in their daily work. And in brief, the answer was that yes, the psychiatrists felt more stigmatized than the GPs, moderately, not excessively, I have to say, but about 20% perceived stigma as a serious problem, which correlated with discriminating experiences and self-stigma, and was more pronounced in less experienced professionals. Since then, the European Psychiatric Association has embarked on producing a number of guidance documents, not only on this topic, and the recent one of this was EPA guidance on improving the image of psychiatry. There are negative perceptions which we all know about in the lay public. There is an overestimation of coercion in psychiatry. The biopsychosocial model, which we all, I think, confess to, is insufficiently elaborated and not successfully translated to the public. There seems to be no clear-cut line between normality and psychopathology, which gives the lay people the impression that we do not know what we are talking about. Classification moves from one pole to the other. One disorder is tomorrow no more a disorder, and vice versa. So what can we with this discipline? And there is a critical view on psychopharmacological treatment. There is the prejudice of second choice treatment with questionable concepts. How can you treat a mental disorder with a drug? And the effect sizes are questions as well. So this is reinforcing the stigma as well of mental disorders and their treatment. So what we need is to reform not just the image, but a little bit more. We have to build ourselves more self-esteem, more self-confidence, and stop the self-stigma, which plays a role in all of these matters. We should promote psychiatry as a unique inter- or multidisciplinary approach in the field of mental health and mental health care. We should represent in the public a positive self-image and increase trust in psychiatry and psychiatrists. And we should integrate mental and physical health care in order to strengthen psychiatry's status as a medical profession and its integration into general medicine. And finally, we should promote psychiatry early among medical students and improve recruitment into psychiatry. We are not, as I said in the beginning, alone in the world. There are many other professions working together with us. And you see, there is a diversity of the workforce in mental health services across the EU. The red are the nurses, the blue ones on the bottom are the psychiatrists, the green is the psychologist, then the social workers, and the occupational therapists. And you see, for instance, Norway and Finland, where you see the green arrows on the bottom, have the highest number of psychiatrists. The lowest rates are found in Malta, in red, and in Sweden. So obviously, we have to think about this situation, of course, as well, and I'm grateful that WHO Europe has taken the initiative to bring together different professions in a work group, so from psychologists and nurses and social workers and so on. They have met several times and had produced a position paper. We need to work together, and we have to redefine or define the roles each of us have. I think this is an important goal for the future as well. And to end, we all have to build strategic alliances at the EU level and, of course, beyond. And if we see all these sponsors on the first slides which we saw for this Congress, this exactly underscores we have to have these many co-operations across various disciplines, but also the family organizations and the patients' organizations belong to this. And this is something, my last slide, the exchange and dialogue with other groups. This is something which we have newly initiated for the EPA Congress every year, where stakeholders of different kinds, policymakers, governmental people, people from the European Commission, and so on, come together to discuss common pressing problems. And the last forum was under the title A Common Language in Psychiatry, in European Psychiatry. Can it be achieved? And with this, let me briefly conclude. Psychiatry is a profession with an exceptional biopsychosocial position among the medical disciplines. Psychiatry across Europe is diverse, but psychiatrists in all countries face very similar challenges. Moving towards a European psychiatry with common standards, goals, means, and mutual support is a must and requires major efforts. Correcting and reforming identity, quality, and public image of psychiatry and psychiatrists are prerequisites in building trust and respect and help counteract stigma and discrimination. And finally, the European Psychiatric Association supports this process through developing a common language and speaking in one voice across countries and professions in the field of mental health in Europe. And with this, let me invite you to participate in the next annual Congress in Florence of the European Psychiatric Association next year in early April. And interestingly, the topic, the motto is Together for Mental Health, and that's what we all want to do. Thank you very much.